This month's lecture will be on thyroid ultrasound and will be presented by Dr. Linwood Hammers. Dr. Hammers, feel free to get started.
Okay, thank you, Mary. I think you can see I'm going to talk on thyroid, and if we have time to discuss some of the lymph nodes in the neck, particularly in relationship to thyroid disease, thyroid cancer. Hope to present to you today generalized thyroid, thyroiditis, Graves' disease, as well as nodules. And I hope to that you take away from this that there are certain nodules you should biopsy and there are certain nodules you should not biopsy because they are essentially 100% benign. I also want to show you in real time how I do a biopsy, and hopefully you can utilize this in your future practice. I think you can see that I'm now a clinical associate professor of radiology and internal medicine at Yale. For 16 years I was at Yale and ran the Department of Ultrasound, and now I'm in private practice. So in the first slide, I have an outpatient practice. I perform about 11,000 ultrasounds a year, and about 7,000 of them are thyroids or head and neck. As far as I know, I do about 50% more than all the docs at the Mayo Clinic put together, as I perform about 2,600 thyroid lymph node biopsies per year. If you can see, I put that I attempt to reject unnecessary biopsies. Sometimes the doctors request that I definitely do it, and I will do it, even though I know it's benign. We put through a lot of patients, and our office is very organized, and I have very efficient workers. And if you're going to run a practice and hopefully to do a lot of thyroid or even any procedures at all, you need to relax the patients by education and being on time. Now, I think any practice or any hospital is going to have a mission. So my mission in terms of the thyroid is to identify and biopsy the potential surgical thyroid lymph node or salivary. And I say potential surgical. I didn't say cancer, because some lesions or nodules are a potential surgical lesion, such as follicular or Hürthle cell neoplasia, rather than indicating a definitive cancer until surgery is performed. I want to identify and biopsy any potential cancer reoccurrence or lymph node metastasis both pre and post-surgery. You don't want to diagnose a patient with thyroid cancer, ignore the lymph nodes in the lateral neck, and the patient goes to surgery and then have recurrent disease and possibly a more distal metastatic disease. And I put in here the parathyroid because that's a major portion of what I do. However, we would not be discussing that today. My referring doctors have changed over the years. Typically, they would just have me biopsy a palpable mass or a nodule seen on an outside ultrasound. This has progressed to where it's a specific nodule plus anything I think is suspicious. And I have several groups or doctors who just send the patient to me, and I do what I think is appropriate. I feel that they get the best service because I'm not biopsying unnecessary nodules. When we prepare a patient for a potential biopsy or evaluation of the thyroid or lymph nodes, we scan the patient. I try to relax the patient by having the patient in an upright position. I don't think it's appropriate to be scanning the patient, hovering over the patient. They get nervous and anxious. It's very important in the thyroid to know the history. Is there a family history of thyroid cancer? Any personal history of radiation or any other cancers? Because this may affect whether you biopsy. A large number of women have diagnosed thyroid nodules after breast cancer. Doesn't mean they have thyroid cancer, but they're often anxious and will request a biopsy. I like to know whether they've had prior biopsies. Many patients come in having had 10 biopsies performed on a thyroid nodule. To me, that is ridiculous. They typically make between 2 and 3 passes only. You also want to know whether they're on blood thinners. I will biopsy patients on blood thinners. That has no problem at all. I've never experienced any major bleed. And you also want to know whether they've been on the internet, because there's some scary procedures presented on the internet by individuals that are very aggressive. I'll let the patient know that 50% of the population does have nodules, and that does not necessarily mean they have any cancer. I will use various transducers. If you're going to do ultrasound, you have to use various transducers to maximize what you're looking at. Sometimes I will use primarily the 12.5 megahertz transducer. but I do all my biopsies with the linear 15.7 megahertz transducer. Sometimes I will actually utilize the curved array transducer, particularly in a very large patient if I have to look below the clavicle for a biopsy. I like to explain the biopsy in detail, and I explain to them because the needle is a third of the diameter of the needle used for blood drawing, the total discomfort is similar to blood drawing or having a shot. Excuse me. I obtain material 95% of the time. In my experience as well, when I see a nodule and I think it's benign and I get a non-diagnostic, I've never had a patient go to surgery for them to find cancer. I think the number around the country is of essentially 75% obtaining material. And hopefully you'll be able to understand how I have better numbers by biopsying the periphery of the mass. I have the patient participate by putting pressure at the site of the biopsy, and I will offer for them to see how I do this. This often gets the patient engaged, and they will perhaps ignore any discomfort that they do have. At Yale in this area, the biopsy results are typically within a week, and if they ask any questions as to what I think, I will tell them. I'm not going to lie to them. These are the transducers. You see the little 15.7 megahertz transducer. With this transducer, I can be more definitive where the needle is. It's more of a superficial scanning transducer. However, you can also get into the suprasternal region, particularly in thin patients, and be able to direct your needle. I utilize a Gestalt approach when I look at nodules. That's an area of pattern recognition. I compare it to other nodules within the thyroid. And please remember, if the patient has abnormal lymph nodes, this can key as to what you're going to do by biopsying the lymph nodes and or the thyroid. Now, I categorize everything. I created a sheet many years ago when I started my own practice, and I will put on this sheet whether I think the nodule I see is benign, indeterminate. By that I mean it could be surgical, it could be a cancer, or anything suspicious, which I have strong concern that there is a cancer. As you can see the sheet there, I have the thyroid drawn in with the vessels, and we place the categories. This is the level 6 region between the carotid arteries, and you can see inferiorly, this is going to be the level 4, the level 3, the level 2, and level 5. These are areas that you have to document if you see lymph nodes where they are, so the proper surgery can be performed. Level 1 is the area just beneath the chin. This is very, very infrequently the site of any metastatic disease. So what's a normal thyroid look like? Here's a normal longitudinal. It's relatively homogeneous. Here's a transverse imaging with the carotid artery and the trachea seen here. And these are benign lymph nodes that are oval with what we call a normal echogenic center. So why do I categorize this, any of these nodules or lymph nodes? It's a self-assessment. Take a look at it with the next patient you have. Determine what you think it is beforehand. Make a note. You don't need to necessarily dictate it out unless that's what you're doing in your area. It enhances the learning curve. I've learned a lot over the years by making a statement and finding out whether I'm right or wrong. And in my situation, building a practice with the competition of Yale and various hospitals in the area, this has really helped me build my practice because the clinicians trust my judgment. So let's look at these categories. The first category is benign. What do we mean by benign? This is a nodule that has a lace-like pattern of fluid. This is sometimes called honeycomb. This is a benign nodule. So essentially, benign nodules are what not to biopsy. I don't think that you should try biopsying these. Now, you may be forced to by some physicians. However, if it is a cyst with or without debris, you leave it alone. If the patient is symptomatic, it could be hemorrhage, and you may want to aspirate it with a slightly larger needle, which is typically going to be the 18 or 20 gauge needle. You don't want to biopsy that honeycomb appearance, and you don't want to biopsy echogenic foci with comet tail artifact. That's classic for colloid. Now, I would tell you I get a large number of patients are sent to me, and if they allow me to make the decision, I put that hockey stick on. It allows you to see the comet tail much better and to determine whether it's comet tail or calcium. So utilize the 15.7 megahertz transducer. However, if there is a cyst with calcium or a solid vascular mass, you may want to be more aggressive. Now, if you have a heterogeneous or diffuse appearance, you may have a pseudonodular appearance seen with thyroiditis or Graves. This is probably the most common reason, as well as the question of comet tail versus calcification that I have sent to me. We probably have 10 to 12 patients with thyroiditis per day, and outside scans say, oh, there's a nodule. A nodule is going to be a discrete structure, not a diffuse area. You will look to see if there is a discrete mass, because you will biopsy that, and you're going to look for calcification. A multinodular goiter, I don't want to biopsy, and I put here question increase in size. From my work over the years, I think an increase in size is the least valuable of any decision-making tree for biopsying a structure. However, if there is one nodule that is different than the others in what looks to be multinodular goiter, or with indeterminate or suspicious features, I will biopsy, because that nodule that looks a little different could represent a follicular or Hürthle cell neoplasia. So let's go back. What's benign? This is a classic colloid cyst. I'm not going to touch that unless somebody tells me they're in a lot of pain. This is benign structure. This is a colloid cyst. I think you can see the comet tail shadowing here. We see it here. This is a benign structure. It's not going to be cancer, and I would tend to leave this alone. Also, these benign nodules are the ones that when you do biopsy, these are the ones that have the risk of having a non-diagnostic. In my hands, as I said, we get material 95% of the time. The ones that tend to be non-diagnostic are ones like this if I am forced to biopsy. Again, in the right lower quadrant or corner here, another benign nodule. This is classic for hemorrhagic cysts, whether it's in the thyroid, whether it's in the ovary, whether it's in the breast of a woman. These are benign nodules. You can see the scattered echoes. If they're having a lot of pain, you put a needle into it and drain it. Now, occasionally you may put a needle into this and you don't get anything out because it's so thick, it's like petroleum jelly. If that is the case, you can give some lidocaine and then put a larger needle such as a 16 gauge. Now, this is a classic picture of multinodular goiter. You have several nodules as you see here. Here's another nodule. And what do these look like? These look like those old pillows pushed together, or I think there were seats many years ago that just sort of came together, and they don't really form a discrete area that's just pushing everything out of the way a real mass would be. That is typical for multinodular goiter. Now, if you see a thyroglossal duct cyst in the midline superior, you're typically going to leave them alone. Again, unless the patient's having discomfort, they're often cystic. I will tell you, though, over the years, I have seen an occasional cancer, but we'll be discussing those features which would be typical for there or within the thyroid itself. Now, as I said, thyroid nodules are often overcalled in thyroiditis. What they represent are lymphocytic infiltrates. You will look for a definite mass or calcification. If you do see a mass and it's very hypoechoic, this could be a cancer, whether it be papillary, it could be anaplastic, or it could be a lymphoma. If you see calcification, you're more concerned about papillary. And if it's echogenic mass within thyroiditis, consider follicular or Hürthle cell neoplasm. So here is thyroiditis. Transverse image, trachea. Patient was sent in because of a mass here. This is not a mass. This is a pseudonodule thyroiditis. Here we see another area. This is a classic benign thyroiditis. This is not a discrete mass. This is all secondary to the chronic inflammation or autoimmune process. Another patient sent in for nodules. These are not nodules. On this, you can see some more normal echogenic material in this region here, but again, this is thyroiditis. Often as the thyroiditis is long-standing, the nodule on the out, or not the nodule, but the thyroid itself will become lobulated, and that'll make people think more and more that there is a nodule. Here is a patient. I see a tremendous number of pediatric patients. In fact, I should write it up. I have over 500 patients that I've seen, and I think the largest paper in the world is about 75 patients. Probably have over 100 and something biopsies on these patients. This is that classic small little hypoechoic areas within the thyroid in a patient who is young and at an early stage of thyroiditis. You don't want to miss this, and you don't want to call this any cancer. This is Graves' disease, looking very similar to thyroiditis. It's a diffuse process, often very bulky in appearance. These patients present clinically typically with hyperthyroidism rather than hypothyroidism. I will tell you that occasionally I have seen patients who have thyroiditis who are hyperthyroid. Here's a picture of Graves' disease. We had scanned the patient, more of a normal looking thyroid at this point, came back 2 years later, and the thyroid is extremely bulky and heterogeneous. Now we go into the indeterminate category. Indeterminate means I can't tell with 100% what this is. I will tell you that I think I can look at about 98% of thyroid nodules. I'm talking everything that comes through, and they're benign. There's less than 1% that I look at that I can tell is cancer, and then you have 1.5%, somewhere to 2% that are indeterminate. That is probably the number that we should be biopsying, about 2 to 3% of thyroid nodules. However, we all biopsy more than that because the clinicians are often anxious or the patient is anxious. So indeterminate means, is it a surgical lesion or could it be cancer? When I was in my training, a nodule with peripheral calcification was benign. It's not true. These have a relatively high risk of cancer, and I'll show you some cases. Here is another nodule. This is a nodule that's relatively isoechoic to the thyroid. It is bulging out from the thyroid through the isthmus. This is an indeterminate nodule, and this pattern is often seen in follicular or Hürthle cell neoplasia. Here is thyroiditis. Again, another picture, this diffuse pattern, but lo and behold, the patient has a nodule within. There is a little cystic component, but you're going to biopsy this, and this came back as a thyroid cancer. Here is Graves' disease. This one, again, you see the hypervascularity often commented on the Graves' disease. You see a nodule, and if you look real close, there's a little punctate calcification. This, to me, was more definitive or suggestive of a thyroid cancer, and this came back as thyroid cancer. If I see discrete masses in Graves' or thyroiditis, they raise concern. Now, follicular and Hürthle cell neoplasias can have varied echogenicity. They can be hyperechoic, they can be hypoechoic, or they can be isoechoic. Often, because these are nodules, they will have decreased central echogenicity because they are a tumor that has outgrown its blood supply, and you may have fluid centrally. They're often well marginated, and occasionally you'll see an irregular asymmetric wall. You can put a needle into that, but you're still not going to make the diagnosis of a Hürthle or follicular cell cancer based on the biopsy. If you find that it is a Hürthle cell or follicular, they need to know, and the doctor will inform that 25 to 40% are cancer, and they can either do a follow-up surgery, or in our area we're doing a lot of genomic testing. Veracyte came out initially, Asuragen, and now at our institution they've developed their own genomic testing. So any of these cases that are read as FLUS, follicular lesion of unknown significance, or nuclear atypia, we are sending out genomic testing. Just remember that occasionally you're going to have a follicular neoplasia, and they're going to open it up, take it out, and you're going to find some foci of papillary cancer. So here's a patient, well-marginated mass. You see some central fluid. It almost looks like there's a scarring effect going centrally. This is a neoplasia. Here is a cancer. It's more hypoechoic, which to me raises more concern than the other one for a definite cancer. And you can see the echo characteristics are similar to the adjacent muscle. There is vascular flow. Does not mean that it is cancer, but it makes you more suggestive that this is not a hemorrhage. Here is a Hürthle cell cancer, heterogeneous, well marginated, and this is compared to a Hürthle cell neoplasia. Again, very difficult to distinguish, but you're going to biopsy because of the findings that we talked about previously. Now we go to the suspicious. This is what everybody wants to know. I want to know whether this is a cancer. How can you tell? Well, If you can see on this one, this is some of the primary patterns we've seen with calcification. You can have cystic component within. And this, if there's any slide, I think this is being taped, but this is a slide that you should probably remember or try to remember when you're doing your ultrasound of the thyroid. This is a conglomeration of findings around the world. I'll tell you what I rely on mostly, and let's go through this. Number one, if you see abnormal lymph nodes with calcification, cystic or possibly heterogeneous, you have to be very suspicious that there is a cancer. And I'll show you a case where didn't see anything in the thyroid, but the lymph node was abnormal and there was cancer. Know the family history, personal history of radiation. It can be from somebody treated for lymphoma. At one point they were radiating for acne as well as tonsils, and we live near New London, Connecticut, where there's the nuclear subs. And I had a patient today, 32 years of working on a nuclear sub. I don't think it's cancer, but they do have an increased risk. I think it's very important if a patient has a PET scan that's positive. This is very, very suspicious. Very rarely is there a negative unless the patient's had recent surgery and there's inflammation. Nuclear medicine, if there's a solid cold mass, I will biopsy this as well. It's important to know this. Now the calcifications can be that micro or punctate, linear or curvilinear, eggshell, can be complete. I am more concerned typically if it's intermittent and peripheral. I think this is more suggestive of a thyroid cancer, although again, complete can be cancer. What about these large areas of calcification? Some of them are central. If it is central, then you need to take some history. Is the patient on blood thinners? Have they had prior biopsies? You may have a patient that you biopsied 3 or 4 years ago, and now they come back with central calcification. With knowing that history, you're not going to re-biopsy, but if you don't have any history like that and you're uncertain, you will biopsy. I think the risk of cancer is less, but it is there. If you have a markedly hypoechoic mass, as we saw that other one, you compare it to the muscles. You want to look for thyroiditis in Graves, as we said, for calcification or a definite mass. I don't like bulging borders. This is something I observed about 15, 16 years ago. And when you see that, take a look at the adjacent muscles, see if there's any vessel penetration, because there could be invasion into the adjacent structures. Now, many years ago, all we do is, well, there's a 2-centimeter mass, you biopsy, it's cancer. If you are going to capture the biopsies in your area, you have to give that surgeon all the knowledge he needs before he goes in, or her. Is it invading into the musculature, and they need to plan on that. If you see an irregular, poorly defined, or microlobulated borders on the mass, think of those of you who are doing breast ultrasound. It can be a very similar appearance. The South Koreans have done some of the primary work in the last several years, and they utilize the taller than wide. I haven't found it as valuable, but I do use it. If there is a cyst with calcification or increased vascularity, biopsy it. If you have a diffuse hypoechoic area in an elderly, you have to be concerned about anaplastic. Now, I put question dominant nodule. I don't think having a dominant nodule would mean there's any cancer. If I think it's benign, I'll try not to biopsy it, but most clinicians are still taught that. Vascularity, I think, is a very low priority for whether it's cancer, but it will affect. If I see vascularity, I may biopsy rather than leaving it alone. So in the literature, people would suggest that one of these criteria has a high sensitivity, and the more criteria you have, the more definitive you can be that this is a cancer. So let's take a look. I'm going to sort of go down through that list of what I showed. We're going to take a look at lymph nodes first. Here's a patient I scanned, thyroiditis. There is no mass, there is no calcium. The look in the lateral neck. Here's a lymph node with calcium. Biopsy that, found a cancer, and they took the patient to surgery and found a minute cancer in the thyroid. So look at those lymph nodes. Here's a patient who had bilateral papillary CA. So we look at the right, there's 2 nodules here. On the left, I'm more concerned because of this intermittent peripheral calcification. But on the right, I see this lymph node that is not a normal looking lymph node. So I biopsy that, and we'll definitely biopsy these nodules here and this in the patient had bilateral papillary cancer. Here's a patient who had a rim of calcium. Now, when I biopsied this, I don't think I was able to break through on this calcium. However, the lymph nodes are markedly abnormal, and we made the diagnosis with the lymph nodes. Here's a patient that I knew was going to be a thyroid cancer, intermittent calcification, punctate calcification. I biopsied it, and I came back with a non-diagnostic. That is very rare for cancer. Cancers tend to give up cells. However, the patient had this complex cystic lymph node, which I biopsied, came back cancer. So they were able to do the procedure, do the surgery based on the lymph node rather than having me re-biopsy this. Now, as I said, family history is important. Patient comes in, family history, there's no palpable mass, and what do I look at? I look and see a hypoechoic mass, a little irregular here, and it is taller than it is wide. Right here's the trachea. This was cancer. Here's a patient with family history, again, just screening because somebody in the family had cancer, and what do we see? A nodule here that is somewhat isoechoic, but there is punctate calcification, cancer. Here's a patient who had a history of radiation as a child. This patient had lymphoma, came in, we biopsied, and this was papillary cancer. This was not lymphoma. Here's a patient also with a history of radiation. We're screening because of the radiation, and we see this mass, and that's cancer. Now, we have a large number of people who come to Yale to study, and actually a significant number from the Chernobyl area. And we have found multiple cancers in these patients over the years. And these would be under that radiation history. Here's a patient who was sent to me as a consult. There's a nodule. I think I'm feeling something. What do you see here? You're going to describe this to the doctors as a hypoechoic mass with somewhat irregular borders and in a subcapsular position without definitive penetration through the capsule. Biopsy, cancer. Now, this is a very important case because this was sent to me because they did a CAT scan on a patient because of a palpable right lateral neck mass. They saw some calcium, so they sent the patient to me. So what do we look at? Well, number one, isthmus. This is classic papillary cancer. It's sort of pushing beyond the borders. Here is an intermittent not calcified nodule on the rim. And here we'll show you in the next one is a bulging mass. So let's look at this bulging mass. What do we see here? Here is the hypoechoic fat. Here is the mass, but where is the borders? Is this the border? See how this is somewhat brighter in here? All three of these were biopsied, and they all three came back cancer, and this was invasion into the adjacent musculature. Here's the trachea, and this mass, which they kept saying was a branchial cleft cyst, I said was a metastatic lymph node, and when they removed it, it was a metastatic lymph node. Cystic lymph nodes are very common in papillary cancer. Here's a picture that we often see in young patients. Again, I should write this up. This is a patient who had been followed for several years and saying they had thyroiditis. Well, what this patient has is bilateral punctate calcifications in both lobes. This is bilateral thyroid cancer. Now, surprisingly, young patients do very well. They can have lymph nodes all over, but they have surgery and they tend to live out a normal life. Here's the curvilinear calcifications as well as peripheral intermittent calcification as well as central punctate. Here is that hypoechoic mass I talked about, and look, the borders are irregular here. So this is, whether you can call this more aggressive, that's for the pathologist or cytologist, not for us, and here it is transversely. Here is a cystic papillary. Now, the fact that there is this tissue here doesn't typically bother me to any great degree. It is vascular, however, but that could be a follicular neoplasia that has involuted or bled. But what do we see here? Calcification. So to me, this is a papillary cancer, and that's what it was. Here's a patient that came in with this mass and a large amount of fluid. I drained 35 cc's from this. I biopsied this before I drained it, and this was papillary cancer with a large amount of fluid. Here is thyroiditis, diffusely heterogeneous, an area of calcification. This is cancer. Here's a patient that you may or may not appreciate. This is thyroiditis, and there is a cancer. This is it right here. This can be very subtle. Sometimes you look at it, with thyroiditis, you often have linear scarring, tissue like this, but this is cancer, and I think there was a second foci right here with this little punctate. Just put the needle, slide it right along the trachea there. Here's another patient, hypoechoic, irregular borders. This is a papillary cancer. Sometimes in elderly patients, similar to younger pediatric patients, you can have a diffuse enlargement. It could be anaplastic, but this patient not only has that, but these punctate calcifications throughout it, and that's a massive thyroid. This is the trachea, trying to get everything on one slide. Now, as I said, if you're going to do this, you have to do the best job. You have to prove that you can do it better than anybody else in the university, anybody else in the community. So what do we see here? Hypoechoic mass, calcification. Again, look at the muscle here. It's whiter here. This is invasion. Here's another patient. You can see the capsule of the thyroid here. You can see this breaking through, and then you can see the vascular flow coming into the muscle. Now, as I said, nuclear medicine, if it's cold nodule and it's solid, I'll biopsy. If it's a cyst, I will drain it, only if it's symptomatic, or biopsy if it has calcium. If there is a positive PET scan, I think you need to biopsy it, unless it is inflammatory and abscess. So here, as I said, we see a lot of patients who've had breast cancer. They have a PET scan. Here's a mass in the thyroid. I don't think there's any question to any of you. This is the carotid artery. Here's a transverse. This is the trachea. This is a mass that is abnormal and needs to be biopsied. Here is an anaplastic cancer. You can't tell that by looking at it. I mean, you're more suspicious if it's an elderly patient, perhaps in their 70s. These are very aggressive cancers. So you have thyroid cancer, which is papillary, which is one of the least aggressive cancers you're ever going to run into, versus probably the most aggressive cancer as well, along with the pancreatic CA. Now, medullary cancer is often familial. You'll have families with MEN2, so there's other things that could be going on. So here's a nodule with calcium. You can't really tell the difference between that and papillary. I will tell you that I have seen a fair number of bilateral medullary cancers. This is the right, this is the left. Here is a patient that actually survived for about 10 years. He was a sailor and wrote books and gave me some books on sailing, although I'm not a sailor. This was the cancer. Here is the mass longitudinally. Here is the mass extending into the lateral neck, and what's important here, here's the carotid artery. This is the internal jugular vein. It spread into the internal jugular vein. He had that removed, had that ligated, and as I said, he survived 10 years where they were expecting him, 2 years to 3 years at the most. Tall cell variant, this is typically another aggressive tumor. This, again, you cannot tell. All you know is you need to biopsy this because of the calcification and its marked hypoechogenicity. Now, I told you I don't utilize vascular to any great degree. However, here is a patient I looked, here's a hypoechoic nodule in the isthmus. Could be a complex cyst, leave it alone. But I put the Doppler on and it was very vascular. I biopsied it and it was a thyroid cancer. Now, lymphomas are rare involving the thyroid. They're often in long-standing thyroiditis. They're hypoechoic, and you're going to look for lymph nodes in the surrounding areas. If you do a fine needle biopsy, you can do that initially, but you also want to do a flow cytometry. There's a big debate whether to do a core from the very beginning. Most of the doctors now are asking for core biopsies of these, and you're going to utilize either a 16 or an 18 gauge needle to do the thyroid and or the lymph nodes. So here's a patient, long-standing thyroiditis, large hypoechoic mass. I look at this and I say this is either anaplastic or this is lymphoma. Big lymph node, still going to be anaplastic or lymphoma. It came back to be lymphoma. Now, my protocol for biopsy is perhaps a little bit different. I've lectured at RSNA, other places, and people talk about using core biopsies for the thyroid. I don't think it's necessary. And people talk about laying the patient down, stretching their neck. You do that with an older patient, they're going to have a lot of discomfort. So here's how I do the biopsy. You can utilize this. You can make it your own, or you can do whatever you feel is best for you. I biopsy everything with a 15.7 megahertz transducer. I can get in there and I can see things better. We clean the neck and the transducer with alcohol. We don't use betadine. This is not a surgical field. You just clean them. I don't use any lidocaine. I spray with chloral hydrate. I have the patient in a sitting position. I'm looking them in the eyes. I don't want to hover over them. I have them lift their chin slightly, and if necessary, I have them rotate the neck so I can get into the lymph node or the thyroid nodule better. I have them breathe normally. If for any reason the patient is having difficulty, I have them take a deep breath, blow it out, and keep it out. I biopsy the right side from the patient's right side and the left side from their left side. Believe me, when you do the large number of biopsies I do, you get shoulder and neck problems if you are stretching and not doing it properly. I would say on a daily basis, moving the needle in and out, since I do 8 to 10 a day, I'm doing that 80 to 100 and something, 150 times a day. I do not place the needle slowly. I'm confident enough at this point. I have it lined up. I know where it's going. I just put it in. If you see people inch it in, they're going to have more discomfort, and then you're going to have the heavy breathing. Typically, I use a 25 gauge needle, rarely the 27. I will document where the needle is. I do not use suction, no syringe. I do not make any more than 3 passes. If I don't get the tissue with 3 passes, and I would tell you 95% of the time I get by with 2. Occasionally I would just make 1 pass. Now you want to biopsy the edge of the nodule or any focal abnormality within, rotating in and out 5 to 10 times. When I do a biopsy, my commitment time-wise is about 2 minutes per nodule, but I spend the time with the patient telling them what's going on. I do not have a cytopathologist. If most of you are in the hospital, you're going to have a cytopathologist. All I find that does is slow me down. At Yale, where across the street from me, they'll take an hour to do 1 biopsy. My time is 2 or 3 minutes, 5 minutes at the most. So it's not practical in terms of time. Now, where do you put the needle? If you see here, you put it on the edge. Or if you have a nodule like this, you look at it, well, that could be follicular neoplasia. If you put the needle in here, it's going to be follicular. If they decide to follow it up, you're going to miss the fact that there is a follicular variant of papillary CA, and this is where you put the needle near the calcification. Now, sometimes, as I said, you have thick calcification. What do? You look, and I see right here a small area that may be a defect. I was able to put the needle into that, and I was able to biopsy that, and that was thyroid cancer. Now, here's a patient who had essentially a hemorrhage, but there was calcification. So I put the needle in, I took the fluid out, and this was blood. This was not a cancer, but it had calcified because of the hemorrhage. Now, these next couple cases, I'm going to show you in real time how I do the biopsy. Hopefully this will come through, and you can see how I actually do the biopsies. So let's go. Here's the first one. Here's a superficial nodule that was seen on an outside exam. They want me to biopsy that, and I do the biopsy. You see I go to the edge. I don't go to the center. Now, what else was important on that? You saw me moving in and out within that nodule. Now, in that same patient, and I'll put the arrow where I want you to look, the patient had another area which I biopsied, which is down here, and you can see there's calcium. At the end here, you'll see right there's the needle, and this was thyroid cancer. So the nodule that they wanted me to do, I went into the one area that was benign, but the thyroid cancer was deep. Look at all aspects of the nodule. Here's the patient, and this is important. You put the needle in. You see I have the needle in the center, and look, I'm going over to the edge here. Okay? So that's the first biopsy. My second biopsy on that patient, I go to the other edge. You want to get representative tissue, and that finds the cancer. Again, stay away from the center. Here is another patient where, again, I go in, I find where I want to be. I go to the edge. I'm on the lateral aspect. This is the left lobe of the thyroid. Now, I will tell you, since I face the patient, I don't have enough space in my rooms to go from the patient's head. I always will start with the right side on a patient if we're doing both. Why? Because I can go through without hitting a muscle, whereas the left side, you almost always hit some muscle, and they may have greater discomfort on the left side. So you get the patient's confidence. They're less discomfort on the right side than you go to the left. So here's the same patient, and what do I do? Again, I'm going sort of in the center, and then I work it over to the right, the medial aspect of this, and this was cancer. Now, sometimes, as I said, you're going to be asked to biopsy a patient who has probably a benign nodule. What are you going to do? You're going to go, this is primarily cystic, where am I? Right on the border, right there. And this is a benign nodule, and I was able to make the diagnosis rather than the patient having a non-diagnostic. So slide preparation, at least at Yale, we only make 2 slides. I put a drop on one, I slide it, one is air dried, one is sprayed. We then take whatever other material, we place it within cytolite and rinse it. As I said, core biopsies are rare. Flow cytometry may require additional biopsies. BRAF is sent automatically if it's indeterminate or positive biopsy. Lymph node thyroglobulins, I send if requested. I have not found any patient that I've ever biopsied a lymph node that they found a positive thyroglobulin with a negative lymph node biopsies. My lymph nodes have all been positive if the thyroglobulin has been positive. And if it's a fluid collection, again, just drain it. This is what you would wish for. I'd like to say I get this on every one, but I do not. Sometimes I'll just have little pieces of tissue like this. I am very fortunate. We have the busiest cytopathology lab in the country, and they are excellent. So after a biopsy, patient can return to work. There's no monitoring. I explain to them that it's similar to blood being drawn. We offer an ice pack, and they can take analgesics. Complications are rare. Here you see I biopsy this, and the patient had a hemorrhage. I hit a small superficial vessel. That's why I give them some tissue to put onto that area. What happens if you have limited material? You make your passes. I made 2 and I don't have anything. Sometimes I'll use the 27 gauge, particularly if there's a firm nodule. You feel like you're putting needle through leather. Surprisingly, a smaller nodule or using suction may get more tissue. If it's only blood, I put it in cytolite. If I can't penetrate calcium, I look for smaller openings. If they have deeper irregular breaths, have them take a deep breath and blow it out. If they're anxious, order anti-anxiety medication. If the patient faints or is lightheaded, you put them supine with cold washcloth. If there's difficulty getting a safe angle, I will rotate the neck, and often that will allow me to see, particularly for lymph nodes behind the carotid artery. I can slide either behind the carotid, or I can slide between the carotid artery and the internal jugular. Time savers, my techs get everything ready for me. We use alcohol rather than betadine. There's no lidocaine. We don't monitor the patients post-procedure. They just get up and walk out. It's like having blood drawn. At the hospitals, they keep patients around for a half hour. To me, that is just creates anxiety for the patient. Again, in my office, if a patient signs in and they're there for a biopsy, they're typically leaving within 30 minutes. Key points, my office is well organized. We're very efficient. As I said, I do maybe 10 biopsies a day, probably a sonohistogram, breast biopsy, liver biopsies. I do them, all those in my office. Very important, utilize various transducers. I find that 15-7 is optimal. And when you do the biopsy with that, reverse it so you're coming over the toe of the transducer. And that way you can get into small little areas. Place it on the border or any specific area you're concerned about, and you only want to biopsy things that are indeterminate or suspicious. Again, I have excellent cytopathologists. Now, there's a lot of debate now going on. Do we biopsy too many nodules? Many people say yes, there's many nodules, few cancers, it's relatively non-aggressive. And I tell patients, if you're going to have a cancer in life, this is probably the one to have, because you'll live out it typically a normal life. 95% of people survive and die of something else. However, some patients want to know, and even a small 5mm papillary can metastasize. So here I'll show you. Let's just assume every one of you out there, this is your thyroid, and you have this, you can see it's about a 3 to 4mm nodule. What do you do with this? This patient elected for me to biopsy. There's calcification, and there's a cancer. I will also mention to you that because of the large number of thyroid cancers that are diagnosed, particularly in countries such as North Korea, there is a major change in our area, in Sloan Kettering, to not biopsy or not surgically remove nodules unless they're a centimeter or greater. So at Yale, this nodule here, at this stage, if we were to biopsy this today, they would probably do an alcohol injection to, as long as there's no other cancers identified. Now, I'm going to do this real quick. I think we have a couple minutes. I just want to show you, when you're looking at a nodule, a patient is sent for this large nodule, and yeah, there's a large nodule. But what do you see here? Here's a border. Here's the cancer. This is a small cancer. If I put the needle in here, this is benign. This is like a 3mm cancer. So look at all aspects of it. Here's a patient with a nodule here. Could be follicular. Could be follicular. This one you're more concerned about cancer because it is hypoechoic. This came out follicular. This came out papillary cancer. So where do you put the needle here? Well, here's a cystic mass, but there's calcium. You put the needle here, and this was cancer. How about this? Palpable mass here. You can put the needle there, but put the needle here where the cancer is, just adjacent to it, and nobody had felt that. Another patient with calcified cystic mass, you're going to put the needle in this area here, or possibly even but you don't put it in the center. Here's a patient with a large nodule. They want me to biopsy. I'll biopsy because there's some calcium, but it looks benign. Other nodules, but here in the isthmus is the cancer. So you make sure that you biopsy this as well as what the doctor wants, but this is the cancer. Here's a nodule, palpable. If this is in a endocrinologist's office and they don't have ultrasound, they'll put the needle here, and you got to make sure this is the cancer, this is the one with calcium. Nodule here, peripheral calcium, that's cancer. Cystic mass, it's palpated. Other nodules, but here's the cancer superior to the cystic mass. No need to do anything with that. Okay, now I've gotten up to the point of abnormal lymph nodes. I see we have 12 minutes left. Mary, you still there?
Yes, I am.
I guess the question is, if anybody has any questions, or if they want, I can go through the lymph nodes quickly. It depends on what everybody wants. If they want, I can run over a couple minutes. I don't know what the feelings are. Maybe you can ask the people what they would want me to do.
Feel free to continue. I do have one question that came in.
Okay.
It says, if you have a mildly suspicious nodule that you don't feel needs biopsy, but you want to follow up, what is your time frame? 6 months, 12 months, etc.
A year. I see too many docs say, oh, 3 months, 6 months. Thyroid nodules are not going to change in any, low period of time. I will suggest a year to see what happens. And again, because these are relatively non-aggressive tumors, if they're small and you have less concern, a year is more than adequate. If it does change within that time, you can be more aggressive, but do not bring the patient back in 3 months. That's just padding your pocket. Any other questions? Don't
patients feel pain when no lidocaine is used for biopsy?
They will feel some discomfort. Most people say it's like having blood drawn or a shot. I have very few people. I've biopsied 5-year-olds with no lidocaine. I've biopsied 12-year-olds. If you have confidence and you go in and you indicate to them you know what you're doing and the parents are there, you're going to do very well. You just go in, you spray, you tell them what you're going to do, and people do very, very well. Obviously, there is an occasional patient. I had a patient today who is just hysterical about the needles. I was able to do the biopsy, but she was just anxious and she wouldn't let me go past two biopsies. I thought I needed more material to do 3. But most people do not have problems if you do the lidocaine. I stopped 20 years ago because the people had more pain with the lidocaine than if I just did it without any lidocaine. So I think everybody's experience is different. This is one thing I know when I lecture. People go, oh my God, he's doing it without lidocaine. But most endocrinologists will not use lidocaine. It's only the radiologist, and we have tended over the years to do the lidocaine. Any other questions?
No, I don't see any.
Okay, let me go through the lymph nodes. I think this is important. We'll summarize this, and if I have to, I'll skip through it, but at least you'll be able to see this. So lymph nodes, as we saw a couple cases before. Calcification, cystic aspects are abnormal, asymmetric, or lobulated. They're round or heterogeneous. And if you see a chain of lymph nodes, either pre, or this is my form for post-op. Again, level 6 between the carotids, level 4, level 3, level 2, level 5. Level 5 is very important because that will affect what surgery. If you have level 5, they are typically going to do a modified radical where you can have certain post-op changes such as an aroma. Secondary findings, loss of an echogenic center does not mean it's cancer. You look for blood flow. Lymph nodes will tend to have a draping blood flow rather than going, if they're abnormal. If they're going through the center, that is more the normal pattern of the flow of the material through the lymph node. And I put down here biopsy and/or thyroglobulin aspiration. I haven't found it to be of any value. I have 2 doctors who utilize it, but most people do not. So let's look at the post-thyroidectomy patients. Surveillance. We do a large number of these. I essentially see almost, I don't know, I get patients from UConn at the medical school. They send them to me because we've had greater success evaluating these patients. You want to know when they had the surgery. You do not want to scan them before 6 months because you're not going to be able to tell what's post-surgical versus routine mass. You want to know what type of surgery, and really you want to know who performed it. Knowing most of the docs in the state, and particularly in the Yale community, I know who does what. I know who tends to have more problems. You can't say that. You're not going to say that to any patient, but I need to know who is performing it. Yale has 4 fabulous surgeons, and they are some of the ones who define what the thyroid surgery is like. I want to know where the side of the primary. If they're going to have recurrence, it's typically going to be on that side. If they had a bilateral, obviously you need to know that. You want to know whether it was a micro or a macro cancer. Was it less than 1 centimeter? Did they have positive lymph nodes? Did they need I-131? If they had no positive lymph nodes, did not need I-131, it was micro, the risk of them having cancer is very, very little. You want to know the thyroglobulin level. Were there any recent exams that raised concern, whether PET, MRI, ultrasound, or nuclear medicine? And you want to know if they had allergies or recent colds, because that can make a lymph node look abnormal. Somebody was asking about when to follow up. If I have a patient who has post-op and has scattered lymph nodes, but the blood work is normal, I'll have them come back in 3 months when they're not in an inflamed state. You don't want to miss anything at all. Lateral neck, you want to identify exactly where you see these lymph nodes. The surgeons want to know. The surgeons love the drawings. If you don't have the drawings at your place, you may want to consider creating some drawings or a way of expressing exactly where these are. L5, as I said, is very important. Now, here are some lymph nodes. I think I'm going to show you just some basic lymph nodes. Here's the carotid, here's the internal jugular, here's the lobulated lymph node, here's another lymph node with a cystic component here. This is a big lymph node with calcium. Here's a lymph node with cystic, calcification, and lobulated. Here's a lymph node with calcification, and here in the thyroid bed post-op, there's a hypoechoic mass between the carotid and the trachea. To do a biopsy, I'll just slide it right through here. And here's an example. Here's an L4 met. Now, when you are identifying where the mass is, if it is anywhere posterior to the carotid artery, it is a level 4, a level 3, or a level 2. If it is entirely medial to the carotid artery, that's when it's a level 6. So you have to know how your doctor is looking at these, because you don't want to say it's a level 6. They go in looking level 6 and it's over here. It's very important. Now, here are the subtle ones, and I want you to see these, because with lymph nodes, both pre and post surgery, I tend to be very aggressive. Why? If the patient is going to go to surgery, they want to remove everything. If I find a lymph node, that's going to affect how they do the surgery. So when I look at lymph nodes, and here was a lymph node, this is the only thing this patient had, and if you look at it, it's somewhat lobulated, bigger on the one edge. I put the needle in this portion, not here, and this came back as a lymph node metastasis, and it did not involve the entirety of the lymph node. Similar to this one, this is transverse. This is, in a sense, a level 3, level 4 lymph node. Here's the echogenic center, but it's asymmetric. This is a transverse. These usually run longitudinal, so you put the needle in here, and this was cancer. Here's a patient who had a partial thyroidectomy, which is uncommon for a thyroid cancer. Patient had a mass right here next to the trachea. Biopsied, it was cancer. Lymph nodes can be hypoechoic, they can be vascular, and you biopsy it. Post-op and looking in the bed, masses, you want to be very aggressive. I will tell you, today I had a patient we looked at post-op. Recent blood works were normal, although the most recent one was not. She had a hypoechoic area, and I called the doc and I said, I think it could be hypoechoic fat. Fat can change and become hypoechoic post-surgery. It can be 1 year, 10 years later we see it. But they wanted a biopsy, and it was fat. I could tell when I put the needle into it, and you get very little material. However, if it is rounded and well marginated, you got to be aggressive and biopsy, because you want to make sure that they don't have any recurrence. Again, calcification, vascular flow, and cystic or post-op. Here you see I put vascular flow. I have found post-surgery lymph nodes will sometimes have vascular flow, which make me want to be more aggressive. So here's a patient in the left fossa. Here's a cancer. Here's a cancer. Here is a hypoechoic mass, somewhat ill-defined, but it is abnormal post-op. Here it is on the left. Patient had bilateral residual cancer. Here's a patient with a small area. This is like 3 millimeters. But what do I see? It's echogenic. I question whether this is a granuloma. I put the color flow on, and it is vascular. Biopsy it right here, and it is a cancer. They will remove this. Here's what a scar looks like. This is granuloma. Many people look at this and say, oh, this is calcified metastatic disease. What you will see on this, if you can, ask the doctor, what did they use? This is seen more in patients who use silk to sew up. These are very, very bright, typically even brighter than calcification. And here you see it here. I biopsied this because I couldn't tell for sure, but this was granuloma. Now, I will quickly mention neuromas. These are scar tissue that affects the nerve that's been damaged. It can look similar to lymph nodes. This is from Dr. Udelsman, who is the head surgeon at Yale. And what happens is when they do the cut here, the nerve can be cut, and this is the spinal accessory nerve. It's usually seen in the radical or modified radical neck dissections. It can be very painful. I've had patients who, when I first started doing this, I tried putting a needle in and they were ready to slug me. After a while, you realize what it is, and I've had patients who've come in from other places and they talk about, trying to do a core biopsy on these. They are unbelievably painful. Injecting with lidocaine does not help. So you want to be fairly definitive. These are typically in the lateral neck. They're lobulated, elongated, tapered ends. They can be cystic, and they can also be painful to palpation. So if you see something you're not sure, press on it with your finger. You know where it is, and see if they have pain. So here's one of the early patients. My tech measured this and said, okay, here's a lymph node. But let's look. See this coming down? Coming down here? That's the nerve. This is the neuroma. Here's another one, same thing. Measure this hypoechoic area, but look, here's the nerve coming in here, here's the nerve coming out here. These are typically best seen on longitudinal imaging. Another one, classic tapered edges. So, in conclusion, know your surgical history. Lateral neck is very important. You want to scan in oblique, longitudinal planes. Stop the biopsy if it's painful. In any patient, you want to biopsy only those that are indeterminate or suspicious. Size is not an important factor. It's still in the literature, the endocrinologists, even in the radiology literature, you know, big things, biopsy. You can do it, but it doesn't mean it's cancer. Lymph nodes are extremely important. Look in the lateral neck. I find what keeps me busy is most people in the state here in Connecticut don't look at the lateral neck. That's why I get them from all over the state. If there's reoccurrence or concern, be aggressive. Be very aggressive. I will tell you that I have a large series of patients who have abnormal lymph nodes and the thyroglobulin levels are normal. You know, think about that. That you go based on the imaging, not with the thyroglobulin. Make the prospective call, continually reassess, and that's the end. This would be for the next doing parathyroids. So I am done at this point. Mary, if there's any other questions, I'll be more than happy to answer. Any comments, please begin.
It doesn't look like there's any questions at this point.
Okay. Okay. Well, thank you very much.
Thank you very much, Dr. Hammers. We really appreciate your time and a wonderful lecture.
Okay. Thank you very much. Goodbye now.
Bye.